Hello, this is Dr. Neelkamal Soares. I'm a developmental behavioral pediatrician at Western Michigan University home of Stryker MD School of Medicine in Kalamazoo, Michigan. And this is Module 12, which is Emerging Topics for the Michigan LEND program. Today we're going to do Part 2, which is Telehealth in Children with Disabilities. The Michigan LEND program is funded under the Autism Collaboration Accountability Research Education Support, or the CARES Act, and administered by HRSA's Maternal Child Health Bureau. Its primary site is Wayne State University, and it consists of the major academic institutions across Michigan. My disclosures: I have no financial conflicts of interest to disclose related to the contents of this presentation, and this presentation's content should not be construed as legal or medical advice. It's for information only. Technology and legislation and regulations are moving at such a rapid pace that this information is current only as of August 2017, when this presentation was recorded. Please endeavor to stay abreast of more recent developments when you intend to apply some of the principles you learn in this presentation. So the objectives of our presentation today is to recognize how telehealth can be used to serve the needs of children with disabilities, and we'll see some specific examples of telehealth use in Michigan. Understand the legal and regulatory barriers to be addressed in order to maintain and launch a successful telehealth program, and to formulate strategies for trainees to develop interdisciplinary care using telehealth. So a little bit about myself and why I'm interested and passionate about telehealth to begin with. So it started in rural Kentucky, where I was working in a small practice, and I'd been there for 3 years, and I finally transitioned to be more of an academician. But that location of the university health center was 100 miles away from my primary clinic. And I was concerned what would happen to my rural patients. How would they access me? How would I continue their care? It was pretty extensive for me to drive down there regularly, and pretty prohibitive for them to drive up to see me. And so I decided at the time that I could partner with some of the hospitals and clinics in the service area and use telehealth and continue to provide access to my patients across a wide range of eastern Kentucky, which is geographically very difficult to navigate. There's small rural roads, and there's mountainous topography, and there's no public transportation system to speak of. So for about 4 years, till 2012, I continued to do this and was very successful in maintaining my relationship with my patients and not having travel barriers for them. And then I moved on to be an academician at UCLA, and in Los Angeles, people would say, what's the point in having telehealth? Isn't telehealth for rural areas? Why would you care about doing it in a big urban place? For the same reason as the rural areas, access. And access is a huge problem even in the Los Angeles County area, because transportation barriers exist for different reasons. It's not that there are no transportation options. It's just that they're very tedious to navigate, and short distances could take a large amount of time. And some poorer populations also struggle to have their own vehicles. And so again, I developed a telehealth program for some of the surrounding valley areas, so they didn't have to come into the city. Worked with a community center in Ventura County, and for 2 years I continued to provide access to patients there. I then moved to central Pennsylvania, which was a lot like Kentucky, pretty rural. And then I began to do more than just clinical care. I began to take administrative roles, develop new programs, not just in developmental behavioral pediatrics, but helping other clinicians develop their programs. So I learned about the regulatory and logistical and operational matters related to telehealth. And now I'm pretty happy to be here in Michigan, and I've been working with Michigan State University as they develop their autism telehealth program, which we'll talk about in a little bit. So you have to understand first the definitions, telemedicine and telehealth. And telehealth is a broader definition than telemedicine, which is considered to be specifically clinical. But telehealth can be non-clinical things like education and training, and also is more embracing of services from allied health providers like speech, occupational therapy, also other disciplines like psychology and audiology and behavior analysis. And the definition of telehealth from HRSA's Office for the Advancement of Telehealth is the use of electronic information and telecommunications to support long-distance clinical care, education, which is both patient education and professional education, public health, and health administration. Why even consider telehealth? As I had alluded to in my personal journey, access barriers are huge, and there's also cultural reasons. Some patients and families are very wedded to their communities. They don't like to go outside of their communities. They are intimidated by certain, urban areas with many specialists tend to congregate. There's also professional isolation. They can't get healthcare professionals to some of these rural areas, and there's less continuity of care. The medical home model is not sustained if patients self-refer to different places because of lack of access. And of course, one might argue that specialists could do outreach, and in fact, specialists do outreach in many communities in this country, but that leads to a lot of unproductive travel time, specialists driving, staying in hotels, spending a lot of time when they could be seeing patients, and this further compounds the access barriers. Why is this important for individuals with disabilities? So, as we had just said, there's a lack of specialists, and especially in rural areas, and that's the primary obstacle. You don't find speech pathologists who are trained to work with people with developmental disabilities, developmental behavioral pediatricians, board-certified behavior analysts. A lot of them are not really available in many areas where these individuals live. The school systems in rural areas also struggle in having specialists, and so then interventions and evaluations get delivered by probably slightly less qualified or uncertified personnel, and this leads to an impact on the fidelity and the reliability of some of these interventions. It's not always possible for therapists to travel to wide rural areas, a lot of travel time again, or for families to keep traveling back and forth to school systems. And as we're all aware, the numbers of certain types of disabilities have been growing, and so this disparity in access continues to be compounded. Telehealth is not a brand new thing. In fact, it's been going on since the 1960s. And in the late 60s, early 70s, really the military, out of sheer necessity because of the great distances between bases and where specialists were available, was an early adopter. And if you can see on the right-hand side, that's actually a telemedicine cart, if you will. This is a cart similar to one that I've seen in Alaska. Some of my colleagues in Anchorage have used equipment like this. They're very expensive, very cumbersome, difficult to move around, but very reliable, good, strong equipment, good quality equipment. But given the expense and the constraints, many of these programs were initially grant funded, mainly for medical applications, for one healthcare provider to consult to another one, or for a healthcare provider to see a patient. It was also used for distance learning, and at the time there were no regulations around reimbursement, and so this was mainly to deliver service and not really as a revenue generation. And coming forward now, we've got amazing options. We've got fixed solutions where we have computers hardwired into the wall. We've got kiosks where you can step in and be connected with a service provider. With the explosion in mobile devices, you have mobile solutions. You've got a wide variety of what are called peripherals, things that you can plug into equipment, everything from high-speed cameras that you can control remotely to electronic stethoscopes, otoscopes to look in the ear, ability to take images of skin lesions, you name it. And a lot of this is moving from hardware solutions to software programs where you're able to video conference. If any of you are familiar with commercial programs like Skype and FaceTime, that's where the field is going, away from having a single computer connected to a single computer. Speaking of communications, the map shows that broadband and wireless networks have blanketed the U.S. apart from some of the desert and mountainous regions. It's pretty prevalent in many places. There's more than one service provider. The cost has gone down substantially from the 80s and 90s, and the quality of some of the solutions has improved as competition increases. Smartphones now are about between 88 to 92% penetration. It's amazing how many smartphone users there are, and as you can see in the bar graph, it has gone up from 46% to almost 90% utilization. So some of the telehealth language you have to be familiar with. Asynchronous is something that doesn't happen in real time or at the same time. So it's something like taking an image, so you snap a picture of, say, a skin lesion, a rash, and then send it and somebody looks at it later. So it's asynchronous, also known as store and forward. You have synchronous, which is video conferencing that's real time and people can see each other and talk to each other in real time. There's remote monitoring where data is collected and then sent. You would say, how is that different from asynchronous? Well, it's happening real time from patients, but it's not video. It's other types of data. It's blood pressure, it's blood sugar, it's body weight, and that is sent in. It can either be sent automatically or the patient has to press a button or enter some information and it gets sent. And then mHealth are things like mobile applications or apps and other sensors and wearables which are used to deliver either care or information. And there's some overlap between these, but this is just some of the terms you need to know for the rest of our presentation. Some examples of using telehealth, we'll talk about the medical field first before we move on. So for example, people who are in the hospital may have suffered a stroke. You can have a neurologist come through the video conferencing equipment and be able to evaluate the person. You can have psychiatry provide consultation to somebody who's having a behavioral crisis in the hospital. You can have outpatient consultations. Again, as you can see, somebody's taking a picture of somebody's hands and sending that on, or you can have direct communication. A nurse or a medical assistant can be in the room if necessary to help facilitate the connection and the information. That's called telepresenting. We'll come to that in a bit. There are other examples, especially when you look at the world of mobile applications and mobile devices. A very popular one now is something called e-visit or on-demand healthcare, anywhere, anytime, and somebody wants to see a doctor, they just tap on the app. In a few minutes they get connected through video with a provider, and this is found to have a lot of patient satisfaction and instant access in this world of instant gratification. There have been thoughts that it might actually reduce urgent care and emergency department visits by having some simple things like rashes and colds, etc., sore throats be seen by this way. It hasn't gained universal traction, but it certainly has been adopted more and more. Michigan has had some examples where healthcare networks and insurance companies have been offering this as a service. And then remote patient monitoring, particularly for chronic diseases like diabetes and asthma and heart failure, is where things that patients have in their homes collects data and send it over to the healthcare team. And this helps them find out how the patient is doing when they're not in the hospital or in the outpatient clinic, so they can keep a better eye on them and close their gaps in care. Things are happening around the country. An example, in California, UC Davis Children's Hospital has been doing things like specialists from the intensive care and emergency department consult to remote hospitals, newborn nurseries. Audiology has been happening, where you have an audiologist through telehealth consulting, particularly pediatric audiologists consulting with community audiologists far away. Feeding teams help with newborn nurseries, and parent-child interaction therapy has been done for behavior management of certain disruptive behaviors. What UC Davis did is look at the financial benefits and found that there's about a $2 return for each dollar invested, so almost twice as much return on investment for telehealth for certain types of projects. Internationally, this has been a big thing, because you can imagine the savings from not having teams of people travel internationally. Globalization is certainly a buzzword. There are a lot of things in global health that are in now. Some great examples of complementary skills are India, where I do some of my telemedicine work, is incredible in infectious disease, tropical medicine, dermatology, and at the same time, they have shortages of rheumatologists and developmental pediatricians. So this is a natural fit where, mutually desirable specialties can be shared. Johns Hopkins has been working with teams in Nicaragua to help in pre- and post-operative care of children with cleft lip, cleft palate. And Miami Children's Hospital has been doing global telehealth consultations in the Caribbean. And there are many other examples, which just shows this is not limited to any one region or state. It's global. Michigan is not far behind. The leader in telehealth in Michigan is certainly in neurology and epilepsy, and DHHS has had clinics where served through specialists connecting through video conferencing from the major children's hospitals. There's also a variant of telehealth which combines the asynchronous and the synchronous, and that's child psychiatry out of University of Michigan to several Michigan counties, including Kalamazoo, where they have the collaborative care model, or MC3, where phone consultations are available, but video consultations, telepsychiatry as needed, are also provided. And I had mentioned Michigan State University, which has a grant right now working on improving consultation to physicians regarding care of children with autism spectrum, beginning in the Upper Peninsula and then expanding to other areas. LEND has been involved in other states in telehealth as well. And so some great examples are audiology in North Carolina, where an audiologist consults with a remote audiologist, helps them understand where to place the probe, what procedures are there in diagnostics. Functional behavior assessments and functional communication training are done for families in Minnesota and western Wisconsin through the Minnesota LEND, and this even happens in home with families. And Tennessee has been doing teleconsultations for families through their early intervention teams. So there are great examples of how telehealth is being used by different LEND organizations, and we're hopeful that Michigan LEND will follow suit. Behavioral telehealth has taken off in a big way around the country. There's a lot of evidence supporting it. And areas in where behavioral telehealth has been helpful in children are telepsychiatry and telepsychology, consultations, evaluations, follow-ups. Behavior analysts have been collecting data in naturalistic environments like special ed classrooms and guiding the teachers and other professionals in delivering assessments and collecting data and also delivering some interventions. And then a great example out of Kansas is where university teams with community teams like psychology have been working together on autism diagnostics. In Seattle and Washington, you've got psychiatrists and psychologists involved in parent training and telepsychiatry for men management in ADHD. So there's a lot of examples where behavioral health has leveraged telehealth very well. So now that I've talked about some examples, let's talk about some of the regulatory issues. These are important to learn if you are going to implement or understand a program. So there are different layers. There's licensure layers, reimbursement or payment areas, and credentialing or verification areas. So let's look at some of these, not in extensive detail, but just so you understand. So some of the licensure things, it really depends on your state. Licensure is a local or state issue. There is yet no federal license for telehealth, and so the question is, does your state approve a telemedicine only license, or does it need a full license? And Michigan is an example of a full license state. California is one where you can get just a telemedicine license and not have to have a full license. Federal programs are wonderful in the sense that even though they may cross many, many states, you could have the Indian Health Service in many Western states, you only need to be licensed in the state you're in. Otherwise, the rule of licensure is you have to be licensed in every state where the patient presents. We'll come to that in a minute. But the federal programs, Department of Defense, Veterans Administration are exceptions. Michigan, unfortunately, gets a low grade in licensure regulations because part of the rules of telehealth encounters is that in addition to regular consent that you have to get from a patient, you have to also get additional consent for telehealth. And there are very few states which require that. And Georgia and Texas actually have the worst ratings because they don't really allow you to do telehealth in isolation. They require you to make the person come in after a telehealth encounter, which sort of defeats the purpose if you think about somebody 150 miles away and they're so glad to do a telehealth encounter with you 5 miles from their home, and then they have to come 150 miles to see you in person anyway. But there's lots of efforts to try and change that in those states. A nice thing about licensure is many states are banding together and saying that if you have a license in one state, you could get expedited license in their states. And in order to qualify, a physician should have a license for at least 3 years and be certified. And as you can see, there are 20 states which have already implemented this. This is moving so rapidly, as I'd said, things will change by the time you see this presentation. There could be more. Just 6 months ago, there were only 17. And Michigan has introduced legislation, and the hope is that it would also pass this. So this would be great where Michigan and Pennsylvania, where I came from, you could get expedited license and see patients in both states through telehealth. This is nothing new. Nurses have been doing this for a long time. There's a single multi-state license which allows nurses to practice in 24 states. Other licensing barriers outside of medicine. So audiology, really there are only 17 states. The latest data is only from 2014. So I'm hopeful there'll be an update soon. Defines telehealth for audiologists, only in 17 states. Only 11 states define telehealth for psychologists, and psychologists generally, not just for telehealth, need to have a license in every state they're practicing it. There's no multi-state license for them. In some cases, they have to pass a licensing exam. Board-certified behavior analysts, some states don't require a separate license for BCBAs. And telehealth rules apply for states where the patient is located. So if there's a state where you're hoping to do, if you're a BCBA and hoping to do a telehealth consultation, it's where the patient sits or the originating site that dictates whether you need to get a license or not where you sit as a professional. Rehabilitation like speech and OT and PT, some states don't cover it, some states do, and those that do cover through licensure. They restrict where services can be delivered. So Michigan, in terms of reimbursement, will cover speech and audiology provided through their school-based program. Who is eligible to be reimbursed? And this is important. It's not good enough getting a license. It's also whether you can bill and collect for your services. And in Michigan, one thing you have to understand is Medicaid is state-based, and to be a Medicaid provider in a state, you have to be registered, licensed in that provider as a provider with Medicaid. And mainly, as you can see, they're mainly healthcare professionals. Those psychologists and social workers are included, but they cannot bill MDCH directly. They have to do it through the mental health equivalent programs. Credentialing and reimbursement. So let's say you're in Wayne State University, Children's Hospital of Michigan, and you want to see a patient in Flint in a hospital there. There was initially rules that you had to be credentialed by the board in both hospitals. But in 2011, the Centers for Medicare and Medicaid at a federal level said that if both hospitals receive Medicare funding, participate in Medicare, then the site where the patient's at, or the originating site, can accept the privileges of where the provider or the specialist is at. Or if they're not participant, they can have a written agreement and it can be the same. And this was a huge burden removed, so you wouldn't have a lot of paperwork and delays. When it comes to reimbursement, Medicare is generally for elderly people and some people with certain types of interventions like chronic renal failure, etc. And so that's at a federal level, whereas Medicaid is at a state level. And reimbursement from private insurances generally follows Medicaid and Medicare. And children in Michigan are generally covered by either private insurance or Medicaid. Only a very small fraction, as I'd mentioned with chronic renal failure, etc., are covered by Medicare. Generally reimbursable in Michigan is only the interactive audio video, not really some of the other things like taking a picture and store and forward. All states now, and this has also improved a couple of years ago, there was only 44 states, and now all states have reimbursement through Medicaid. Some cover remote patient monitoring, some cover the store and forward. Michigan is not one of them. And full parity is important to understand, because that means payment is at the same rate as if you were there in person. And this is important because some systems feel like they're getting shortchanged with less reimbursement when telehealth is in place. Originating site, again, is where the patient is at, and distal is where the clinician is at. Medicare additionally has some restrictions. You don't need to know about this much if you don't deal with seniors and adults, but if you do, you have to understand the originating site has to be an underserved area or a health professional shortage area. Some states don't mention this for Medicaid, but Medicare does. And an example here on the map is in Michigan. These are all the counties, excluding some of the counties in the Upper Peninsula. I couldn't fit it on the slide, but it's the ones which are lighter in color, so either the white or the pale green, that are considered less underserved. So many of these areas, if you had an elderly patient and you wanted to, let's say, deliver telehealth for somebody who has dementia and diabetes, you're plumb out of luck in terms of getting payment if they are in the darker green areas. Now, again, there's work in legislation and in Congress to try and replace this and make it more equitable, so where you live does not dictate what access you get to care. So again, Michigan Medicaid, real-time and not asynchronous, doesn't have to be X number of miles, but it has to be at certain sites. Only the sites listed are included. So realistically speaking, I can't see a patient in their home and hope to get paid by Medicaid for it. And so some of those things I talked about where people on their smartphones are able to connect with a physician, sometimes you've got to give your credit card information and pay for it out of pocket and maybe submit it for reimbursement, but it's not automatically covered. And unlike Georgia and Texas, Michigan does not require that you have to come in person between the healthcare professional and a patient. Now you're wondering, what about privacy and HIPAA, the Health Insurance Portability Accountability Act, which controls what privacy rules apply and how you're supposed to keep information protected. People who don't know much about telehealth think that, wow, you're connecting on the internet, so my images and all my personal health information is out there and somebody can just hack and take it. That's generally not true if you adhere to certain rules, like you've got to treat a telehealth encounter just like you would in person. You've got to have a secure place to keep records. You've got to notify the patient of their rights to privacy. You've got to adhere to the policies, procedures, educate your staff. You've got to use secure connections. Hopefully you're not on a public Wi-Fi in the library or in the grocery store when you're trying to interact with a patient or a client. You have to use platforms that are HIPAA compliant. And by HIPAA compliant, I mean that they have to sign what is called a Business Associates Agreement, or a BAA, and not every video conferencing provider does that. So for the longest time, Apple did not do it and FaceTime was not considered telehealth compliant, but it is now. Zoom, which is a popular video conferencing method for meetings, and you will be doing a Zoom session with me at the end of this module. Zoom has a subsection, which is Zoom for Telehealth, which is HIPAA compliant, but not regular Zoom. And Skype is not, though there is a subsidiary version called Skype for Business, which used to be Microsoft Link, that is telehealth compliant, or HIPAA compliant for telehealth. Some practical pointers. You remember in that picture you had a nurse showing an arm of a patient to a clinician. So that's called telepresenting. Somebody at the originating site knows what to do with the technology, with the patient, with procedures. It requires some training, some orientation. You've got to let people know, and you yourself, if you're going to use this, need to know about what connectivity you're using, what bandwidth you have, what sort of cameras and connections you have, the audio, how well is the audio connected on both sides, is the video seamless, is it pixelated, what software you're using, is it compatible with your computer systems, is your hardware compatible, does it need upgrades? I mean, it's a whole lecture in itself. Some people make their careers in this. There are fields where training is done in telehealth technologies. It's beyond the scope of this, but just to understand, it's not just flipping a switch and saying hi to someone and talking to a client. You have to understand what you're using to connect. Just like you would understand if you were seeing a patient in person or a client in person, you would understand the rules and the regulations and the layout of your clinical space. Scheduling is a little more complicated because you're involving two sets of places, the originating site and the distal site, so you have to know how to coordinate both schedules. And you have to understand the privacy issues. You can't do this with the patient sitting in a conference room or a public area, and you've got to make sure you have rules and regulations around this. What do patients think about this? In general, it's convenient for them. They have less time waiting, especially those in-demand ones. Lower cost is really dependent on what you're using. So some places are offering incentives to use telehealth, particularly lower copays, for example, for using their on-demand e-visit services. However, there are concerns that these type of models don't always connect the patients with their familiar providers. It could be luck of the draw, whoever's available. Generally, the patient satisfaction is high, but there are still people there who don't trust a diagnosis over telemedicine, and would prefer to see the doctor through telehealth, telemedicine, only if they've previously seen them. However, this is changing. The younger generation, compared to some of the previous generations, are more willing to trust some of these technologies. What about the clinicians? Well, they complain that there's not enough literature out there on outcomes and effectiveness and cost effectiveness. They're worried that this type of model would sabotage the trust that is built through a handshake and a hug and being there in person. Many organizations don't like this outside of the medical home, which is you have one place where all of your care resides, because they think this would fragment care. Some providers just don't like the technology. They think there's too many limitations. There are some, but rejecting it outright is really not the best way to approach limitations. Residents, again, just like the younger generation, said they would have absolutely no problem using this. So I believe things are changing from 5-10 years ago. What about the research gaps? Well, it's really hard because different programs are designed differently. They do different things. They use different technologies. They're not really comparable. And much of the research out there is descriptive. They don't have a lot of details to really replicate or compare. There haven't been enough researchers, and now there are more. But at the same time, we've got new approaches where you really don't have any information other than vendor-supported analyses. And so those have to be taken with a grain of salt. So what is the research out there? Well, access is great. As you can imagine, if for people who live in rural areas and live far away from tertiary care centers, this really improves access, especially geographical access. Now, obviously, it doesn't improve access if you only have one person to do it and they have a 3-month wait list. Doesn't make a difference if it's 3 months and you see them by telehealth or you see them in person. But at least you don't have to travel as far. And there's really good evidence that remote patient monitoring for chronic conditions, this is a good way of doing things. There's good evidence to support psychotherapy for behavioral health and counseling for chronic conditions. There's just not enough on comparative outcomes to standard delivery, and there's not enough outcomes on pediatric care or financial aspects yet. There's lots of policies out there, and the number one place to go to, it's freely available, are the policies by the American Telemedicine Association. They have issues as wide-ranging as the operating procedures, how to actually do it, to how to maintain eye contact, which is a critical skill, how you should lay out your environment, what are some of the basic communications modalities and how you should use them. There's guidance on the telepresenters and what they need to do. There's guidance on rehabilitation. There's guidance on telemental health, almost everything, and gets updated every few years. In addition to this organization, there are guidelines from specialty-specific societies. American Psychological Association has something out on telepsychology. And individual states like Ohio was one of the first ones which had telepsychology guidelines in 2010. The Federation for State Medical Boards talks about the appropriate use of telemedicine and frowns on using this outside of the context of a medical home and does not approve of this outside of the state in which you practice, or you have to get multiple licenses or maybe use the interstate compact. There aren't guidelines yet for telespeech, teleaudiology, tele-BCBA, etc. The American Academy of Pediatrics says that research needs to be done, that you should integrate topics into medical education, and so I give talks like this to everything for continuing medical education, to practitioners, to trainees, to help them understand this is an option out there. We should still address some of the licensing and regulatory barriers. They still exist. So, for example, if there's no reimbursement for a speech pathologist to cover telehealth, then there aren't going to be many speech pathologists using this. Always use it in the context of your team and your network. There are resources like the American Telemedicine Association. There's scientific publications where you can read about recent literature, research projects, cutting-edge ideas. And there are telehealth resource centers, and I wanted to point this out because there are different regions around the country, and Michigan falls under the Upper Midwest Telehealth Resource Center, which covers also Illinois, Indiana, and Ohio. And they are a wonderful resource. They provide technical assistance and guidance and policy updates. So depending in which state you live, there's a place to go for help regarding telehealth. So there are 12 of these around the country, and ours is based out of Indiana. Thank you so much. Happy hunting and reading, and we will have a stimulating discussion at our Zoom session.